Hello everyone, I am myself Dr. 𝗂𝐻𝐫𝐢𝐻𝐿𝐵𝐷. I am the General Medicine Educator. So in this particular session I will be doing a quick revision of the topics related to the cardiology. So in which first topic I will be doing the quick revision is on the jugular venous pressure or the jugular venous pulse. So the jugular venous pressure or the jugular venous pulse, it represents the pressure of the right atrium. And at the same time you need to be aware of what is that which will represent the left atrial pressure. So left atrial pressure is represented by the pulmonary capillary wedge pressure, and this pulmonary capillary wedge pressure is measured by 𝐒𝐮𝐬𝐜𝐫𝐢𝐻𝐿𝐵𝐷, right? So it is the internal jugular vein, right? And that too right-sided internal jugular vein which represent the jugular venous pressure, okay? And how much is the normal jugular venous pressure? The normal jugular venous pressure, it is around 6 to 8 centimeters above the right atrium, right? 6 to 8 centimeters above the right atrium. Now you should be also able to differentiate the jugular venous pressure from the carotid pulsations. So if you take the difference between the jugular venous pulsations and as well as the carotid pulsations, jugular venous pulsations, they are superficial and lateral in the neck, whereas the carotid pulsations, they are deeper and medial in the neck. That is carotid pulsations. And if you take the jugular venous pulsations, they are better seen, whereas the carotid pulsations, they are better felt. And you take the jugular venous pulsations, you have the waves, right? And what are these waves? These waves include A, C, X, V and then Y. So these are the waves which are present within the JVP. Whereas you take the carotid, that is pulsatile manner. Okay, so you will be able to feel the pulsations on the palpation, right? And the next important is the effect on the respiration. Jugular venous pressure, it increases on the respiration, or jugular venous pressure, it increases on the inspiration, right? Whereas the carotid pulsations, there is no effect on the respiration. And the jugular venous pulsations, they can be obliterated. So in the sense, when you apply the pressure with the help of a finger over the base of the neck, so the jugular venous pulsations can be obliterated, right? Whereas carotid pulsations, they cannot be obliterated even you apply the pressure over the base of the neck. So these are some of the differences between the jugular venous pulsations and carotid pulsations. So very important is jugular venous pulsations are superficial and lateral in the neck or lateral to the 𝗠𝐵𝐼𝐻𝐵𝐷, whereas the carotid pulsations, they are deep and medial to the 𝗠𝐵𝐼𝐻𝐵𝐷. Now what is very important in the jugular venous pulsations are the waves. So if you take the waves of the JVP, the waves of the JVP, it includes the following, right? They represent the cardiac cycle pattern A, C, X, V and then Y. Then again it repeats A, C and then X. So these are the waves of the JVP. Now what does these wave represents? Let me tell you. So A wave of the JVP, it represents the atrial contraction. So this corresponds to which phase of the cardiac cycle? This corresponds to second rapid filling. Second rapid filling is due to the atrial contraction, which is present in the late diastole, right? Which is present in the late diastole, okay? Then C wave, it is due to bulging of the cusps. Right, C wave, it is due to bulging of the cusp, and that will happen during isovolumetric contraction phase, which is nothing but the early part of the systole, right? Early part of the systole. Then we have the X wave, which represent the atrial relaxation, right? Atrial relaxation. So this corresponds to which phase of the cardiac cycle? This corresponds to the mid systole, right? Then we have ACXV. So V wave, it represents the venous filling, right? V wave, it represents the venous filling. So during that process of the venous filling, right, the ventricle will be in still the state of the contraction. So this corresponds to the late systole, right? Then you take the Y wave. So Y wave, it represents the atrial emptying. So atrial emptying, during this time the AV valves will open and the ventricle will be in a state of relaxation. So this will be the early diastole, right? So this will be the early diastole. So these are the waves of the JVP and the corresponding events in the cardiac cycle, right? Then whenever you are measuring this particular JVP, always remember the position of the patient should be in 45 degrees whenever you are measuring the JVP, right? And the JVP is measured with the help of the two scales. Okay, we will discuss about the abnormalities related to these particular waves of the JVP. So if you take the A wave abnormality, so the A wave abnormality, if you observe, you need to know the conditions where the A wave is absent. The A wave, it is absent in patients with atrial fibrillation, and you need to know the conditions where you have the presence of the giant A wave. Giant A wave, it is present in case of the right atrial myxoma, and it is present in scenarios of tricuspid stenosis, present in scenarios like pulmonary hypertension and then pulmonary stenosis. Then you need to be aware of what are the conditions where you have the presence of the 𝐾𝐼 A wave. So 𝐾𝐼 A wave, it is present in the clinical scenarios like the complete heart block and as well as the junctional rhythm, right, as well as the junctional rhythm. So these are the scenarios, right, where you have the 𝐾𝐼 A wave. So 𝐾𝐼 A wave is that where the pressure within the right atria will increase almost up to 20 millimeters of mercury or beyond 20 millimeters of mercury. These are the abnormalities of the A wave. Then you take the abnormalities related to the X wave. So if you observe the abnormalities related to the X wave, okay, first and foremost, the scenarios where the X wave is accentuated, right? So X wave represent what? That is atrial relaxation, where the pressure within the right atria is dropping down, and there is one condition where there is reversal of the X wave. Reversal of the X wave means the pressure within the right atria is not dropping down, and the condition where the X wave is accentuated is in scenarios like the constrictive pericarditis, in scenarios like the restrictive cardiomyopathy, and in scenarios like the cardiac tamponade. Right, in scenarios like the cardiac tamponade. And you need to know the conditions where you have the reversal of the X wave. The reversal of the X wave is observed in patients with the tricuspid regurgitation, where you have the reversal of the X wave, right? Then you take the abnormalities related to the Y wave, right? And okay, before that, the abnormalities related to the V wave. So you need to know the condition where the V wave is increased. V wave is increased in patients with the tricuspid regurgitation. And finally, you need to be aware of the abnormalities related to Y wave. So Y wave represents what? That is the atrial emptying. So there are certain clinical conditions where the Y wave is absent. There are certain clinical conditions where the Y wave is the accentuated or it is a deep Y wave, right? And there are certain conditions where you have a slow Y descent, right? And there are certain clinical conditions where you have the early Y descent, right? Early Y descent. So now you take the conditions where the Y wave is absent. The conditions where the Y wave is absent is in patients with the cardiac tamponade. And the conditions where the Y wave is accentuated, that is in patients with the constrictive pericarditis and as well as the restrictive cardiomyopathy. And the conditions where you have slow Y descent is in patients with tricuspid stenosis, and early Y descent is observed in tricuspid regurgitation. And lastly, in the JVP, you need to be aware of one important sign called as the 𝐒𝐮𝐬𝐜𝐫𝐢𝐻 sign. What is 𝐒𝐮𝐬𝐜𝐫𝐢𝐻 sign? The 𝐒𝐮𝐬𝐜𝐫𝐢𝐻 sign is that where there is increase in JVP upon inspiration. Normally upon inspiration, the JVP should fall down. But upon inspiration, if the JVP increases, and that is what is called as the 𝐒𝐮𝐬𝐜𝐫𝐢𝐻 sign. And you get this 𝐒𝐮𝐬𝐜𝐫𝐢𝐻 sign in patients with right heart failure. You get this in any condition whichever is causing right heart failure, like tricuspid regurgitation, right ventricular myocardial infarction, pulmonary stenosis, pulmonary hypertension, pulmonary embolism, cor pulmonale, any condition which is causing right heart failure, you will have the presence of the 𝐒𝐮𝐬𝐜𝐫𝐢𝐻 sign. And the other condition where you can have 𝐒𝐮𝐬𝐜𝐫𝐢𝐻 sign is constrictive pericarditis, and as well as the restrictive cardiomyopathy as well. So these are some of the very important points related to the JVP. So after doing a quick revision of the jugular venous pressure, let me do a quick revision of this topic of the heart sounds. So in the heart sounds, first you need to know the areas of the auscultation. So first important area is the aortic area. The aortic area for the auscultation is in the second right intercostal space, right? It is in the second right intercostal space, the parasternal line. And then we have the pulmonary area. The pulmonary area for auscultation is in the second left intercostal space, parasternal line. Then you have very important tricuspid area. So tricuspid area for auscultation, it is in the fourth left intercostal space, parasternal line. And the mitral area, it corresponds to the apex of the heart. Now where is this apex? It is present in the fifth left intercostal space, mid-clavicular line, or half an inch medial to the mid-clavicular line. So this is where you have the mitral area. Now apart from this, you have a very important point for auscultation. This we call it as the 𝐒𝐽𝐵's point. The 𝐒𝐽𝐵's point, it is nothing but the neo-aortic area. Right, it is the neo-aortic area. So the neo-aortic area, it is present in the third left intercostal space, parasternal line, right? So where exactly is this particular 𝐒𝐵's point? It is the place, it is in the third left intercostal space, parasternal line. And very important is, this is the area for the auscultation of the second heart sound. Now followed by this, you need to be aware that there are totally 4 important heart sounds: first, second, then third, and as well as the fourth heart sound. So if you take the first heart sound, it is heard during isovolumetric contraction phase, right? And the second heart sound, it is heard during isovolumetric relaxation phase. And third heart sound, it is heard during the first rapid filling. And fourth heart sound, it is heard during the second rapid filling phase of the ventricle. Okay, so these are the 4 important heart sounds: first, second, third, and as well as the fourth heart sounds, right? And let us just discuss some important points related to the first heart sound. The first heart sound, it is mainly due to the vibration which is generated within the AV valves, right? That is the mitral valve and as well as the tricuspid valve. And what is that you need to know in the first heart sound is, you need to be aware of the abnormalities related to the first heart sound. And the other important point is, if you take the features of the first heart sound, the frequency of the first heart sound, if you observe, it is medium to, right? So it is medium to the high frequency sound. And this particular first heart sound, the duration of the first heart sound, it is around 0.14 seconds, and it has 2 components, that is M1 and as well as T1. And between this M1 and T1, you don't have any split, right? You don't have any physiological split between M1 and T1. So the duration between M1 and T1, it is around 20 to 30 milliseconds. So you don't have the physiological split in the first heart sound. And if you take the abnormalities related to the first heart sound, the abnormalities of the first heart sound is that you need to be aware of the conditions where you will have loud first heart sound, and you need to be aware of the conditions where you will have the soft S1. And you take the loud S1, you get that in patients with the hyperkinetic states. So what are these hyperkinetic states? The hyperkinetic states that include anemia, thyrotoxicosis, beriberi, AV fistula, pregnancy, fever, Paget's disease of bone. These are the hyperkinetic states, right? And then in conditions like short PR interval, you will have the loud S1, and in valvular diseases like the mitral stenosis and as well as tricuspid stenosis, you will have the loud S1, right? So these are the conditions where you will have the presence of loud S1. And the conditions where you have soft S1 is the conditions where there is poor conduction of the sound to the surface of the chest, right? That is in patients like obesity, then in patients with the cardiac tamponade, then in patients with the COPD, then in patients with the left-sided pleural effusion, then in patients with the pericardial effusion, right? Not only the pleural effusion on the left side, even the pericardial effusion. So in these conditions, the transmission of the sound to the surface of the chest will be reduced, and that will cause the soft S1. And valvular heart diseases like mitral regurgitation and tricuspid regurgitation, then calcified mitral stenosis and tricuspid stenosis, because the mobility of the valve will be reduced in these two conditions, calcified MS and as well as TS, and then prolonged PR interval. So these are the conditions where you will have the soft S1, right? Now, after having discussed about the abnormalities, okay, one more important abnormality is the clinical scenario where you have the reversal of the first heart sound. Normally you have like the M1 and as well as T1. But where is that you have the reverse splitting of, right? So what is that condition where you will have the reverse splitting of the first heart sound? So in the sense where you will have T1 followed by that M1. So you will have this in patients with left bundle branch block. So where you will listen T1 first and then followed by that M1. And normally between M1 and as well as T1 you don't have any split, right? M1 and T1 it is being heard as a single sound. But what is the scenario where you will have a split between M1 and T1 is in conditions like right bundle branch block. So reverse splitting of the first heart sound in LBBB, right? The normal pathological split between M1 and T1 is heard in the RBBB, that is right bundle branch block. That is about your first heart sound, and you take the abnormalities related to the second heart sound. Now if you take the characteristic features of the second heart sound, as I have said you, it is best heard in the neo-aortic area, that is in the Erb's point. And if you take the frequency of the second heart sound, it is a high frequency sound, and the duration of the sound is around 0.11 second, and you have two components, the A2 and as well as the P2, right? And if you take the split during inspiration, right, during inspiration you have the presence of the physiological split between A2 and P2, and that particular split is heard because the duration between M1 and the duration between A2 and P2 is 40 to 50 milliseconds. Thereby you will be able to listen the physiological split. But if you take during expiration, this particular split, it disappears, right? So why is that the split disappears? Because the gap between A2 and P2 is less than 30 milliseconds, and always remember the A2 is the one which is heard first, and then followed by that the P2 is heard later. These are the characteristic features of the second heart sound. And this particular second heart sound, as I have already said you, it is heard during isovolumetric relaxation phase, and this second heart sound, it is representing the closure of the it is representing the closure of the semilunar valves, right? And this semilunar valves, it includes the aortic valve and as well as the pulmonary valve, right? And in the pressure graph, it represents the dicrotic notch or incisura, right? Dicrotic notch or the incisura. Now, so first you listen A2 and then you listen P2. Then what are the abnormalities related to the second heart sound, right? The conditions you need to know is the conditions where there is wide splitting of the S2. Normally, right? Normally the split between A2 and P2 is around 40 to 50 milliseconds during inspiration. During expiration it is less than 30 milliseconds, right? But wide splitting of S2, it is mainly due to, right, early A2 and delayed P2. Right, early A2 and as well as delayed P2 is the one which will be causing the wide splitting of the second heart sound. Now, what are the conditions where you have the early A2? You will have this early A2 in patients with mitral regurgitation and ventricular septal defect. And the conditions where you will have the delayed P2, you will have that in patients with complete right bundle branch block. You get that in patients with left ventricular paced beats. You get that in patients with left ventricular ectopic beats and left ventricular ectopic beats, and you get this particular delayed P2 in patients with massive pulmonary embolism, and you get this delayed P2 in patients with the pulmonary hypertension, and you get this delayed P2 in patients with the pulmonary stenosis and then the atrial septal defect. So these are the conditions where you have the delayed P2. So early A2 and as well as delayed P2, right? Then followed by that, you need to know the conditions where you have wide fixed split. Right, wide fixed split. Wide fixed split is observed in case of the atrial septal defect, is observed in case of massive pulmonary embolism, right, is observed in case of the severe pulmonary stenosis. So these are the conditions where you will have. So this massive pulmonary embolism will be causing acute right ventricular failure. So this is a scenario where you will have wide fixed split. But very important condition is the atrial septal defect. Now these are the abnormalities related to the second heart sound. And regarding the abnormalities, you need to know what are the conditions where you will have reverse splitting of the second heart sound. That means where is that you listen P2 then followed by that A2. So the conditions where you will have P2 first and then followed by that the A2. The conditions where you will have the P2 first, that is in WPW syndrome, that is Wolff-Parkinson-White syndrome type B, and the conditions where you will have the A2 later, that you listen in patients with left bundle branch block. In left bundle branch block, the A2 will appear or A2 is heard later. So this is what is called as reverse splitting of the second heart sound, and these are the abnormalities related to the second heart sound. And one more point is the conditions where you listen loud S2, that is in systemic hypertension where you will have loud A2. Then in patients with pulmonary hypertension also you will have loud S2, but here it is due to loud P2 component, right? That was about the second heart sound. Then you take the abnormalities related to the third heart sound. Third heart sound, it is a low pitched sound, right? And as I have already said you, it is heard during the first rapid filling, and it is best heard at the apex because it's a low pitched sound. It is heard best with the bell of the stethoscope. And what is the position in which you will be able to listen this particular third heart sound is, you make the individual to lie down in the left lateral position, and it is heard best at the apex, right? And there are certain, usually third heart sound is not heard. If the third heart sound is being heard, we call this as the ventricular gallop, right? So we call this as the gallop sound or the ventricular gallop, or we also call it as the protodiastolic gallop. And what are the conditions where you will listen the physiological S3? The physiological S3, it is being heard in case of the children and as well as young adults, then pregnancy, right? Children and young adults, then the pregnancy and athletes. So these are the scenarios where you will listen the physiological S3. Then followed by that, you need to know the conditions where you will listen the pathological S3. The conditions where you listen this pathological S3 is in patients with left ventricular failure and as well as the right ventricular failure. Any condition which is causing LVF or the RVF, you will have the pathological S3. Apart from this, even in case of cardiomyopathies, because all these cardiomyopathies will make the individual to land up in heart failure, restrictive cardiomyopathy, hypertrophic cardiomyopathy, or the dilated cardiomyopathy. And even in patients with the constrictive pericarditis, you will be able to listen the pathological S3. And all the hyperkinetic states which is causing heart failure will also have the pathological S3. Then coming to the fourth heart sound. The fourth heart sound, it is also a low pitched sound, right? And it is never heard in a normal individual. If it is heard, it is always pathological, right? And we will be able to listen the fourth heart sound in a normal individual with the help of the phonocardiograph. And if you are listening that pathological S4 with the help of the stethoscope, that we call it as the atrial gallop. Right, that we call it as the atrial gallop, and it is never heard in a normal individual. If in a normal individual, you will be able to listen that only with the help of phonocardiograph, and it is heard during the second rapid filling phase, and it is also heard best at the apex with the bell of the stethoscope. Right, that is pathological S4. Now, what are the conditions where you have the presence of the pathological S4 is in patients with the hypertrophic obstructive cardiomyopathy, and in case of the obstructive valvular heart diseases. This obstructive valvular heart diseases that includes aortic stenosis and pulmonary stenosis. Then in patients with the cardiac tamponade, and you will be able to listen that even in patients with the myocardial infarction, you will be able to listen the fourth heart sound. So these are the four conditions where you'll have pathological S4. Then next is you need to be aware of what is called as the additional sounds. Right? What are the additional heart sounds that can be heard in various pathological conditions are, number one, the opening snap. Then next important is the pericardial knock. Then the another important additional heart sound, it is the tumor plop. Then you have the click, that is ejection click. Right? Ejection click. Now you take this opening snap, it is heard in patients with mitral stenosis and tricuspid stenosis. Pericardial knock is heard in constrictive pericarditis. Tumor plop, it is heard in atrial myxoma. Then ejection click is heard in the aortic stenosis and as well as the pulmonary stenosis. Okay, right? Then you need to know that opening snap, it is the diastolic sound. So even you take the pericardial knock, it is a diastolic sound, whereas tumor plop is also a diastolic sound. But ejection click is heard during the systole. And what about the intensity of the sound? So opening snap, it is the high pitched sound. Pericardial knock is also high pitched sound, whereas tumor plop is a low pitched sound, and ejection click is also a high pitched sound. So the point is, all the heart sounds, all the additional heart sounds are heard during diastole, except ejection click, which is heard during systole. And all the additional heart sounds, they are high pitched sounds, except the tumor plop, which is a low pitched sound. So these are some of the important points related to the abnormalities of the heart sounds. So the next important topic for the quick revision is the infective endocarditis. So infective endocarditis is a scenario where you have the formation of friable infective vegetations over the valves. And this particular, the vegetations, they are highly friable, where the chances of embolization is very high. And these vegetations, they enter into, right, they get fragmented and they enter into the systemic circulation. And the formation of the vegetations over the valves is not just observed only in infective endocarditis. We also observe in case of non-bacterial thrombotic endocarditis, which is also called as merantic endocarditis, which is observed in hypercoagulable states like malignancy. And even in case of rheumatic fever, there can be development of vegetations. And in case of SLE, that is Liebman-Sachs endocarditis. But out of all these, the highly friable vegetations, they are observed in the infective endocarditis. And the least friable are observed in SLE, that is Liebman-Sachs endocarditis, right? And you need to know what is the most common organism that is causing infective endocarditis. The most common organism that will be causing infective endocarditis will be the Staphylococcus aureus. That is the most common organism. And then followed by that, the next most common organism will be the Streptococcus viridans. right? The next most common organism will be the Streptococcus viridans, okay? And this infective endocarditis, we classify that into the following types. Like we have what is called as the acute infective endocarditis, then we have the subacute infective endocarditis, then we have infective endocarditis in IV drug abusers, then lastly we have the prosthetic valve endocarditis. Right? Now, you take acute infective endocarditis. The organism causing acute infective endocarditis, it is the Staphylococcus aureus, which is a highly virulent organism. And the valves which gets affected in acute infective endocarditis will be the normal valves are being affected, and it is a highly virulent organism. Whereas subacute infective endocarditis, it is caused by the streptococci, and the organism will be a low virulent organism, and the previously abnormal valves, right? So it is not the normal valves, it is the abnormal valves which gets affected in case of the subacute infective endocarditis. And you take infective endocarditis in IV drug abusers, it is mainly the right-sided valves which are commonly affected in IV drug abusers, and the organisms causing the infective endocarditis in IV drug abusers will be the Staphylococcus aureus, and the next important organism will be the Candida. Right? The next important organism will be Candida. So predominantly right-sided valves are affected, and that is mainly the tricuspid valve, and followed by that there is involvement of the pulmonary valve. And the source of the organism in IV drug abusers will be the skin, and usually this is common in males rather than females. Then you take prosthetic valve endocarditis. Prosthetic valve endocarditis, we classify this into the early prosthetic valve endocarditis and late prosthetic valve endocarditis. Early prosthetic valve endocarditis is the one which occurs within 2 months of development of the infective endocarditis, within 2 months of the prosthetic valve placement, and after 2 months of the prosthetic valve placement, if there is development of infective endocarditis, that we call it as late prosthetic valve endocarditis. So the most common organism that will be causing the early prosthetic valve endocarditis will be coagulase negative staphylococci, which is nothing but the Staphylococcus epidermidis. And even the late prosthetic valve endocarditis, in 2 to 12 months, right, within 2 to 12 months, the most common organism that will be causing prosthetic valve endocarditis will be your coagulase negative staphylococci, that is Staphylococcus epidermidis. Whereas after 12 months, that is after 1 year, what is the most common organism that will be causing the late prosthetic valve endocarditis? That will be Streptococcus viridans. Right, so that will be the Streptococcus viridans. Okay, so these are the organisms that will be causing prosthetic valve endocarditis. Now you need to know what is the most common clinical feature that you will be having in patients with the infective endocarditis. That is, these patients will have a very high grade fever, right? And in patients with the infective endocarditis, you need to be aware of a very important triad called as the Osler's triad, which is also called as the Austrian syndrome. Right, which is also called as the Austrian syndrome. Now you take this Osler's triad. There are 3 important organs which gets affected in the Osler's triad. That is, there will be infection of the lung parenchyma, that is pneumonia. Then there is infection of the meninges, that will result in the meningitis, and there will be infection of the heart, that is the infective endocarditis, right? And what is the organism that will be causing Osler's or the Osler's triad or the Austrian syndrome is, that is the strep pneumonia, right? That is pneumococci which will be causing this Osler's triad or the Austrian syndrome, right? And the virulent organism that will be causing the valve abscess will be the Staphylococcus aureus. It can cause the valve abscess, right? And if there is development of the valve abscess, these patients require the surgical treatment. And so the most common clinical feature will be the fever. And on examination, these patients will have the presence of the clubbing, and there will be also splenomegaly that is observed in patients with the infective endocarditis, right? And you have some important examination findings, that is the presence of the Osler's nodes, then the Janeway lesions, and as well as rod spots. I'll be discussing that in the criteria. And in order to develop the infective endocarditis, you should be aware of the presence of the predisposing factors, right? The most common predisposing factor that will be responsible for the development of the infective endocarditis is the mitral valve prolapse with mitral regurgitation. This is one of the most important predisposing factor that can predispose the individual to develop infective endocarditis. And at the same time, you need to know what are the high risk lesions for the development of the infective endocarditis. The high risk lesions are mainly the lesions which are across the high pressure gradient. That includes aortic stenosis, aortic regurgitation, then mitral regurgitation, patent ductus arteriosus, ventricular septal defect, tetralogy of Fallot. So these are the conditions, and even the presence of the prosthetic valves. So these are all the high risk lesions for the development of the infective endocarditis, right? Whereas what are the low risk lesions? That is mitral valve prolapse without MR. It is a low risk lesion for the development of the infective endocarditis, right? Now, what is the criteria for the infective endocarditis? Is the modified Duke's criteria, in which you have the major criteria and as well as the minor criteria, right? Major and as well as the minor criteria. So you have 2 important major criteria and 5 important minor criteria. So major criteria is the blood culture, right? So there should be at least 2 cultures that should be positive out of 3. So 2 out of 3 should be positive. That is one. And the second important in the major criteria is the presence of vegetations. So there should be presence of large vegetations, and that will be made out by doing a 2D echo, right? That will be made out by doing a 2D echo. So these are the 2 important major criteria. Whereas you take the minor criteria in these individuals. Number 1, the presence of the fever. The presence of the fever, it is one of the minor criteria, right? And the next important minor criteria is the important examination findings. And one more, there should be presence of the predisposing factor, right? There should be presence of the predisposing factor for the development of the infective endocarditis, right? Then you need to be aware of the vascular phenomena. What are the vascular phenomena that will be causing the that is the part of the minor criteria of infective endocarditis is presence of mycotic aneurysm, intracranial hemorrhage, Janeway lesions. Okay, so Janeway lesion, it is a vascular phenomena. Then you need to be aware of the immunological phenomena in the minor criteria. The immunological phenomena is the glomerulonephritis, then the presence of the Osler's nodes, then rod spots, and even the presence of the rheumatoid factor. That is your minor criteria. And the last one is the microbiological evidence. So microbiological evidence, the one which does not meet the major criteria. So usually in the major criteria, you require 2 cultures to be positive, minimum 2 cultures to be positive out of 3. But here, even if 1 is positive, we consider that under the minor criteria. Now what is the diagnostic criteria? The diagnostic criteria is the presence of the 2 major criteria, or 1 major plus 3 minor criteria, right? Or the presence of all the 5 minor criteria. So these are the diagnostic criteria for the infective endocarditis, right? Now, very important is you need to be aware of the complications which are associated with the development of the infective endocarditis. The complications include the development of the myocardial abscess. Once there is myocardial abscess, these patients will be requiring the surgical treatment. And the other important complications are the valvular stenosis and valvular insufficiency. So there can be even perforation of the valve because of the infective vegetation over the valve. Then there can be the perforation of the aorta, right? There can be perforation of the aorta. So these are the complications which are associated with the development of the infective endocarditis. And the treatment in case of infective endocarditis is you need to give a broad spectrum antibiotic, right? So you need to give vancomycin. And this particular vancomycin, this should be given 1 gram 12th hourly, that is twice daily. And along with that, you need to give ceftriaxone. But whenever you are giving this ceftriaxone, you need to give 2 grams, right? You need to give 2 grams at once in a day. That is the dosage of the vancomycin. And please remember, whenever you are giving these antibiotics, the patient should be afebrile within 7 days. But if the fever is presenting even after 7 days, that is suggestive of the paravalvular abscess. And if there is paravalvular abscess, these patients, they will be requiring surgical treatment. Now, what are the indications for surgical treatment in patients with infective endocarditis is, number one, failure of the medical management. Surgical treatment is required. The presence of myocardial valve abscess, surgical treatment is required. Aortic valve endocarditis, surgical treatment is required because it can cause the complete heart block. Prosthetic valve endocarditis will be requiring surgical treatment, and presence of large vegetation which has the high risk of presence of large vegetation which has the high risk of the embolism. And then in case of the fungal endocarditis, these are the indications for the surgical treatment. And you need to know what are the organisms that will be causing the fungal endocarditis. The organism that will be causing the fungal endocarditis will be Candida, and the another important organism is the Aspergillus, right? And the most commonly associated risk factor for the development of the fungal endocarditis is the IV drug abusers, right? And then the prosthetic valves. So these are the risk factors for the development of the fungal endocarditis, right? So in these patients, the medical management is required. This medical management, it includes the amphotericin B and then supplementation of the flucytosine, right? Amphotericin B and flucytosine, that is a medical management. And surgical treatment that is required in these patients is radical surgical debridement, right? Radical surgical debridement. And these patients with fungal endocarditis, they are the one which are said to be the one with worst prognosis. And which group of individuals will require the infective endocarditis before undergoing the dental procedures? So according to American Heart Association, the following clinical scenarios require the infective endocarditis prophylaxis before the dental procedures. That is the patients with prosthetic valves, right? That is prosthetic valve endocarditis or the presence of the prosthetic valves. These patients will be requiring the infective endocarditis prophylaxis before the dental procedure. And those patients who are having complex cyanotic congenital heart diseases like tetralogy of Fallot, they will be requiring infective endocarditis prophylaxis. Then the cardiac transplant patients who have developed valvulopathy, they will be requiring the infective endocarditis prophylaxis. And in the infective endocarditis prophylaxis, what is that particular regimen that you will be giving is, the regimen that you will be giving for the infective endocarditis prophylaxis is those individuals who are not allergic to penicillin. So in them you can give the amoxicillin. You can give amoxicillin, right? That is oral 2 grams 1 hour before the procedure, right? Now the point is, if the individual is allergic to penicillin, then the oral antibiotic that can be given is the clindamycin, or you can give cephalexin, or you can give the azithromycin or the clarithromycin. So these are the oral formulations. But most of the times what happens is the patients who is undergoing surgery, they will be like, they are put in the NPO status, right? Nil per oral. So parenteral antibiotics are required. And these parenteral antibiotics that need to be given in those individuals who are not allergic to penicillin, we can give ampicillin. But those individuals who are allergic to penicillin, then the parenteral antibiotics that can be given is the clindamycin, or you need to give cefazolin. So this is about the infective endocarditis prophylaxis. So which group of patients will be requiring the infective endocarditis prophylaxis before undergoing the dental procedure? So this completes the quick revision of the infective endocarditis. So let me just do a quick revision of the coronary artery disease. So how do we classify this coronary artery disease is, we classify this particular disease into the 2 forms. One is the angina, right, and the other one is, so angina. So basically in both of the forms you will have angina, but we classify it as the ischemia, and then the infarction, where there is the death of the myocardium. So you take this ischemia. Ischemia, we classify that into like 3 forms. One is the stable angina. Second, we have unstable angina. Right? Or Second we classified as the 𝐒𝐮𝐻𝐸𝐼 angina, right? And third one is the unstable angina. And infarction, we have two forms. One is the non-ST elevation MI and as well as the ST elevation MI. So this is like the classification in case of the coronary artery disease. So out of this, the last three, they come under what is called as the acute coronary syndrome, where there is 100% blockage of the vessel. And what exactly makes the difference between ischemia and infarction is, in both of them there is angina, that is chest pain. But if you take the cardiac biomarkers, the cardiac biomarkers, right, they are negative in case of the ischemia, whereas the cardiac biomarkers, they are positive in case of the infarction. And what are those cardiac biomarkers? These cardiac biomarkers, they include the troponin and as well as the CK-MB, right? So these are the cardiac biomarkers. Now you take this stable angina first. So stable angina is also called as the reversible ischemia, right? And if you observe in case of the chronic stable angina, more than 70% of the luminal diameter is reduced. And why is this more than 70% of the luminal diameter is being reduced? That is due to atherosclerosis. And what will be the clinical features in case of the stable angina? That is the chest pain. And this particular chest pain, it will be retrosternal in location. So retrosternal chest pain. And the duration of the chest pain here, it will be around 10 to 15 minutes. And this particular chest pain, it will not be there at rest. It increases on exertion, or it will be increasing on eating, or it will increase on the emotion. And you need to be aware of this important sign called as the Levine sign. So the Levine sign is that where you, when describing the pain of angina, the individual will clutch the fist over the sternum while describing the pain. That is what is called as the Levine sign. And how is that you need to evaluate the stable angina is the ECG. ECG will show you there is that the non-specific STT changes will be there, and the cardiac biomarkers will be negative. And the way by which you can diagnose is the treadmill test, right? That is the stress test. And those individuals who are not able to diagnose by treadmill test, you need, because like certain individuals, they cannot do a treadmill, right? Let us just assume 80-year-old female who is having obesity and osteoarthritis of the both the knee, they cannot do the treadmill. So in them, you need to do a DSE, that is dobutamine stress echo has to be done in order to diagnose. And the next important point is like how to treat the patients with the chronic stable angina. So if you see the treatment of the chronic stable angina, the drug of choice is the beta blockers, right? And you need to give a single antiplatelet drug. And this single antiplatelet drug, it includes the aspirin, right? Aspirin or the clopidogrel should be given in these individuals. And along with that, you need to give the nitrates, okay? So nitrates, that is nitroglycerin, has to be given, right? And in case of the chronic angina, the another important anti-anginal drug that we have is ranolazine. So ranolazine is also an anti-anginal drug. And the other drugs which can be given to improve the cardiac activity or to reduce the mortality is the ACE inhibitors can be given, right? ACE inhibitors or angiotensin receptor blockers can be given, right? And at this point, you need to know some important points related to the imaging. So like we have what is called as the thallium scan, Muga scan, and as well as the PET scan. So let me tell you about the indications of this particular, the PET scan or the thallium scan. So thallium-201 is a radioactive substance that we use, right? And this thallium-201, it is used in detecting the hibernating myocardium, right? So in detecting hibernating myocardium, we use this particular thallium-201. Then next we have the PET scan, that is positron emission tomography. So positron emission tomography is the one which is used to assess the myocardial viability, right? It is used to assess the myocardial viability, okay? So and the myocardial viability is the one which tells us whether to do the revascularization with the stenting or not. So this is about the chronic stable angina, right? And in the spectrum, like we have, next one is the Prince metal angina. So in case of the Prince-Metal angina, so okay, before that, the treatment is that like we need to give with beta blockers, aspirin and nitrates and ACE inhibitors. But after doing coronary angiogram, if the coronary angiogram shows that there is a blockade more than 70%, then we need to do the PCA, percutaneous coronary intervention has to be done. Then the next important form of the angina is the Prince-Metal angina. So the Prince-Metal angina, which is also called as the variant angina, or it is also called as the vasospastic angina, right? So what exactly happens here? In these patients with Prince-Metal angina, there is a transient coronary vasospasm, and during that coronary vasospasm, the blood supply to the myocardium will be reduced, and thereby the individual will complain of chest pain only during that particular episode of reduced blood supply. And there are certain risk factors for the development of the Prince-Metal angina. One is the female gender itself is one of the risk factor, and that too females with history of migraine, right? Females with history of migraine or the Raynaud's phenomena, right? Or the Raynaud's phenomena. So these are the risk factors for the development of the Prince-Metal angina or the variant angina. And whenever there is the coronary vasospasm, you will have the ST segment elevation, and this particular ST segment elevation, it will be transient ST segment elevation only during that episode of the chest pain. And the coronary artery that is being affected is the right coronary artery is commonly being affected. And when we are using this word spasm, right, spasm is defined as when if the blockade is more than 75%, then we use this word called the spasm, right? Then how is that you will treat these patients with the Prince-Metal angina? So the very important part of the treatment is the smoking cessation. That's a very important part of the treatment. And the next important part of the treatment is what exactly is the drug of choice? The drug of choice will be the nitrates. And the drugs that can be given for the maintenance therapy is you need to give the calcium channel blockers, right? Calcium channel blockers, okay? And we also have a Rho kinase inhibitor, and the example of the Rho kinase inhibitor, that is the Fasudil, right? The Rho kinase inhibitor, it is Fasudil, which will inhibit the acetylcholine induced spasm. And the other drugs that can be given is the statins. So this particular statins also by pleiotropic effect, they prevent the coronary spasm. So this is about the treatment of the Prince-Metal angina, which is also called as the variant angina. Then you take the acute coronary syndrome. Acute coronary syndrome, you have three parts of the spectrum: unstable angina, NSTEMI, and as well as STEMI. So you take in case of unstable angina and as well as non-ST elevation MI, the treatment is same in both of these scenarios, right? But what is the difference in case of unstable angina and as well as NSTEMI? In both of them, the ECG will show you that there is ST segment depression, right? But the cardiac biomarkers, that will be positive in case of non-ST elevation MI, but negative in case of the unstable angina. And these cardiac biomarkers, they include the troponin and as well as the CK-MB. So you take this particular troponin. The troponin and as well as CK-MB, both of them will appear in the blood after 2 to 4 hours. Right? They appear in the blood after 2 to 4 hours. Okay. And when is that they will reach the peak value? The CK-MB, it will reach the peak value within 24 hours, whereas the troponins, it will reach the peak value by 3rd or the 4th day. And the CK-MB, it will return back to normal after 72 hours. After 72 hours, the CK-MB will return back to normal. Whereas the troponins which have been elevated, that will return back to normal after 10 to 14 days. So after like 1 to 2 weeks, the troponin values, they return back to normal, right? Now, in both of them, like what exactly is the treatment? So first and foremost, very important is DAPT. Dual antiplatelet therapy should be given in both of them, right? Oxygen therapy should be given because there is ischemia and as well as infarction. Then nitrates should be given. So in order to ensure that there is coronary artery vasodilatation and there is decrease in preload and afterload by nitrates, we need to give the nitrates, that is nitroglycerin. Then statins are another important group of drugs. And in patients with unstable angina and as well as NSTEMI, the initial revascularization we do with anticoagulant. The anticoagulants that we give is either low molecular weight heparin or the unfractionated heparin or the fondaparinux should be given. right, or the fondaparinux should be given. So these are the anticoagulants that we give in case of the 𝗠𝐮𝐬 and as well as the unstable angina. So once the revascularization is done with the anticoagulants, then you need to do a coronary angiogram. The coronary angiogram, if the blockade is more than 70%, then we do a percutaneous coronary intervention. And very important point here that you need to understand is about the thrombolysis. So thrombolytic therapy, it is avoided in patients with 𝗠𝐮𝐬 and as well as unstable angina. So thrombolytic therapy is not given in these two scenarios, right? Then next important is the STEMI, that is ST elevation MI, right? So ST elevation MI is that where these patients, they are having transmural infarction. So it is the entire myocardium which is completely dead. It is the entire myocardium which is completely dead. That is what is called as the STEMI, that is transmural infarction. And in case of STEMI, right, there should be the ST segment elevation. And like how much should be the ST segment elevation? The ST segment elevation, it should be more than 1 mm in the limb leads, right? It should be more than 1 mm in the limb leads, and the ST segment elevation, it should be more than 2 mm in the chest leads, right? It should be more than 1 mm in the, more than 2 mm in the chest leads, but it should be in contiguous 2 leads. What do you mean by the word contiguous 2 leads? I'll discuss. So you take in case of the lateral wall MI. In lateral wall MI, the ST segment elevation should be there in 1 AVL, V5 and as well as V6, right? So the ST segment elevation should be there in 1 and AVL, or the ST segment elevation should be there in V5 and V6, or it can be in all the leads also. There can be ST segment elevation, but minimum in 2 contiguous leads there should be ST segment elevation. Alright, so that is about in case of lateral wall MI. Whereas you take in case of the inferior wall MI, the ST segment elevation is present in 2-3 AVF, you will have the ST segment elevation. Whereas in anterior wall MI, the ST segment elevation will be there from V1 to V4, you will have ST segment elevation, right? And you take in case of right ventricular MI, the ST segment elevation will be there only in V1 and V2. Along with that, you will have ST segment elevation in 2, 3 and AVF. Okay, so this is how you will be able to diagnose the ST segment elevation MI, where there is 100% blockade of the vessel and transmural infarction is there in case of STEMI. And how is that you will treat this particular STEMI? So the best method of revascularization is PCI, then compared to that of thrombolytic therapy. But what is the first line drug that we give in the treatment of the STEMI is we give aspirin, right? And next to this particular aspirin, you need to give a dual antiplatelet drug. So this dual antiplatelet drug include either clopidogrel or the ticagrelor should be given, right? And another important drug is the statin, right? So DAPT should be given, dual antiplatelet therapy should be given, and along with that the statin has to be given, right? But the best method of revascularization is PCI, then compared to that of the thrombolytic therapy, right? Now the next important part of the treatment is, like when you are doing thrombolysis, what are the various thrombolytic agents that you are aware of? That includes streptokinase, then urokinase, then alteplase, then tenecteplase, right? Then it includes the tenecteplase. So these are the various thrombolytic agents, and out of which the very important thrombolytic agent will be the tenecteplase. It is the one which has the higher chances of revascularization than compared to the other forms of thrombolytic therapy. And the other way by which you can treat is by doing the CABG, that is coronary artery bypass graft. So coronary artery bypass graft, what is the indication is, if there is significant left main coronary artery stenosis, right? If there is significant left main coronary artery stenosis, you need to do CABG, right? And the next important is, if there is a triple vessel disease, involvement of right coronary artery, left anterior descending artery and left circumflex artery. Along with that, if there is left ventricular dysfunction where the ejection fraction is less than 50%, then you need to do the CABG, that is coronary artery bypass graft has to be done, right? And another indication for the CABG is, even though there is two vessel disease, right, where there is involvement of LAD and as well as the LCX, and if the ejection fraction is less than 50%, even that is also the indication for the coronary artery bypass graft. Okay, Right, and when we are doing this coronary artery bypass graft, where is the conduits that we will be using that? We will be using the conduits from saphenous vein grafts and as well as LIMA, that is left internal thoracic artery or left internal mammary artery grafts, what we use in case of the CABG, that is coronary artery bypass graft. Now you need to know the complications. Now you need to know the complications in patients with the STEMI. The complications in case of the STEMI is, they include the electrical complications, that is tachyarrhythmias can be there, that is VT and VF, and bradyarrhythmias can be there, that is in the form of complete heart block, right? And structural complications like mitral regurgitation, that is mainly in case of inferior wall MI and as well as anterior wall MI, ventricular septal defect, that is mainly in anterior wall MI, and even there can be cardiac rupture as well. So these are the structural complications that can be seen in patients with the myocardial infarction. Then followed by that, you need to be very much aware of the late complication, and the late complication is the Dressler syndrome. So Dressler syndrome, it is a post myocardial infarction pericarditis, where it's an inflammatory condition where the individual will have a chest pain, and in these individuals the ESR is elevated and the treatment is the anti-inflammatory drugs. You need to increase the dosage of the aspirin, or the other drugs that can be given is the 𝐒𝐮𝐬𝐜𝐫𝐢𝐻𝐿, or like we give the corticosteroids if the individual is refractory. So this is about the complications related to the myocardial infarction. So this completes the quick revision of the MI, right, or coronary artery disease. The next important topic I'll be doing the quick revision is the hypertension. So if you take the hypertension, we have the two important forms of the hypertension, that is primary and as well as the secondary form of the hypertension. So primary is that where the etiology is not known, right? We call this as the idiopathic. But whereas the secondary hypertension is that where the individual has an underlying etiology for the development of the hypertension. But between these two, which is like the most common cause for hypertension is the primary hypertension. So idiopathic hypertension, which is also called as the essential hypertension, right? Idiopathic, which is also called as the essential hypertension, which is the most common cause for the development of the hypertension. Whereas you take the secondary hypertension. Secondary hypertension is that like the most common cause will be renal parenchymal pathology, right? And this renal parenchymal pathology that includes the glomerulonephritis, it includes the polycystic kidney disease, it includes the obstructive uropathies. And the other important etiology will be the renal artery stenosis, that includes the fibromuscular dysplasia or the atherosclerosis. Then we have some endocrine conditions which will be causing the hypertension, and these endocrine conditions include the Cushing syndrome, 𝐶ON syndrome, hyperthyroidism, hypothyroidism, acromegaly, hyperparathyroidism. These are all the endocrine disorders which will be causing hypertension. And the next important is the coarctation of the aorta and obstructive sleep apnea. Because of intermittent sympathetic arousal, there will be development of the hypertension. And not only that, there are certain drugs or there are certain medications which will be causing hypertension. These medications include the high dose estrogens, right? Then adrenal steroids, then nasal decongestants, appetite suppressants, then we have amphetamines. These are all the drugs which will be causing the hypertension, right? And so 85% the cause will be, right, 85% the etiology will be the primary hypertension, which is also called as the idiopathic, right? Then followed by that, you need to know what exactly is the cutoff for the diagnosis of the hypertension or the diagnosis of the blood pressure. So the cutoff for the diagnosis of the hypertension, first of all, the normal blood pressure, normal systolic blood pressure will be less than 120 and normal diastolic blood pressure will be less than 80. Now when will you use this word called elevated blood pressure? When the systolic blood pressure is in between 120 to 129, then this we call it as the elevated blood pressure. And next is, when do you call it as the hypertension? We use the word hypertension, and when do we call it as stage 1 hypertension? Stage 1 hypertension is that when the blood pressure is in between, the systolic blood pressure is in between 130 to 139 and diastolic blood pressure, it is in between 80 to 89. And the stage 2 hypertension is that when the systolic blood pressure is more than or equal to 150 more than or equal to 140 millimeters of mercury, and diastolic blood pressure is more than 90 millimeters of mercury. So this is like according to American Heart Association. So this is exactly in contrast to the previous guidelines. According to the previous guidelines, we use the term hypertension, right? We use the term stage 1 hypertension when the systolic blood pressure is more than 140. But more than 140, now it is called as the stage 2 hypertension, and more than 130 is considered as hypertension according to the recent guidelines which has been given by the American Heart Association, right? And not just by only one reading we consider that the patient is having hypertension, right? So like minimum 3 OPD visits, out of which at least 2 readings are more than 130 systolic or more than 80 diastolic, then we consider it as the hypertension. That is according to the American Heart Association. Then after that, you need to be aware of the treatment of the hypertension. See, for the secondary causes of hypertension, you need to treat the underlying secondary cause. But for primary cause for hypertension, we need to give the antihypertensives. And what are the antihypertensives that we need to give as a first line? The first line antihypertensive, right? The first line, the antihypertensive will be the diuretics. And this particular diuretics, it includes the thiazide diuretics is what we need to give, right? Whereas in elderly individuals more than 50 years, the first line antihypertensives will be the calcium channel blockers, right? That is the CCBs. But before starting the antihypertensives itself, like we need to advise the lifestyle modification within the individual, right? This particular lifestyle modification include weight reduction. Weight reduction is an important part of the treatment. And next is the diet. The diet should be the DASH diet. That is diet which is rich in fruits and as well as vegetables, right? And next is dietary sodium restriction, right? You need to give like sodium only up to 2.4 grams per day, right? Or you need to give 6 grams of the sodium chloride. And very important part of the lifestyle modification is the physical activity, right? The physical activity. So this is about the lifestyle modification. And among the drugs, the first line will be the diuretics. That is thiazide diuretics in elderly individuals. It is a calcium channel blockers, which is the first line antihypertensive, right? And the other alternative drugs apart from thiazide diuretics or the calcium channel blockers, that includes the ACE inhibitors and the angiotensin receptor blockers. So you take thiazide diuretics, very important precaution is you should not give them in diabetic patients because this will cause hyperglycemia. With calcium channel blockers, mainly like amlodipine, it is associated with pedal edema bilateral. And with ACE inhibitors, there is increase in bradykinin levels which can cause the dry cough. And what are the second line antihypertensive? The second line antihypertensive, that includes the alpha blockers, right? The alpha blockers. And this particular alpha blockers, they include like phentolamine or labetalol. Labetalol is both alpha plus beta blocker, or then we need to give the beta blockers as well, right? We need to give beta blockers as well. So these are the second line antihypertensive drug. And we have one more important form of the hypertension, which is called as the resistant hypertension. Now, what you understand by this word resistant hypertension is that resistant hypertension is that in spite of giving 3 different antihypertensives, right? In spite of giving 3 different antihypertensives of 3 different classes, right? Of 3 different classes, where we are using, right? Where we are using maximum dose of the antihypertensive drug, right? And one among that is the thiazide diuretic. One among that should be the diuretic. Okay, out of these 3, one should be diuretic, and you are using the maximum dose. In spite of that, if the blood pressure is not getting controlled, right, then we use this word called resistant hypertension. What could be the reason for resistant hypertension? First and foremost, very important reason for resistant hypertension is non-compliance, right? If the compliance is not good, then definitely the blood pressure will not decrease. Second important is taking the over-the-counter medications like COX inhibitors or drugs of abuse like cocaine, erythropoietin. So when the individual is also taking these particular drugs, the blood pressure will not get controlled. Or the individual is consuming excess amount of salt along with antihypertensives, the blood pressure will not get controlled, right? And individual is consuming excess amount of alcohol, blood pressure will not be controlled. And the individual is like extremely obese individual, then the blood pressure will not be controlled. This is what is terminology called resistant hypertension. So this completes the quick revision of the topic of the hypertension. So let me just do a quick revision of the ECG. Now first and foremost, you need to be aware of the normal ECG waves, that is P, Q, R, S, T. And you also have an additional wave, that is the U wave. So P wave, it is due to the atrial depolarization, whereas the QRS complex, it is due to the ventricular depolarization, and the T wave, it is due to the ventricular repolarization. So you take the ventricular depolarization, that is from endocardium to the pericardium, whereas ventricular repolarization, it is from the pericardium to the endocardium. Then after having discussed about this PQRST, you have one additional wave, that is the U wave. And this particular U wave is due to activity within the papillary muscles of the heart, right? Now after having discussed about the U wave, next you need to know about the rate, rhythm, and as well as the axis. So how is that you will calculate the heart rate? So you will be able to calculate the heart rate, that is equal to, right, the 300 divided by number of complexes between, right, or the number of large boxes, right, number of large boxes between the RR interval, right, number of large boxes between the RR interval. So that is what is nothing but your heart rate. So the number of large boxes, if you see 1, 2, 3, 4 and 5. So 300 divided by like 5 in this ECG strip, the heart rate is around 60 per minute. So this is how you need to calculate the heart rate. Then coming to the rhythm. So like we have two forms of rhythms. One is regular rhythm and the other one is irregular rhythm. Regular rhythm is that the number of large boxes between the RR interval, right? The number of large boxes between the RR interval, they are equal. Then we call it as the regular rhythm. Then what do you understand by the word irregular rhythm? So irregular rhythm means the number of large boxes between the RR interval is not same. That we call it as the irregular rhythm, right? And when you take the example of this ECG, this is the ECG of ventricular bigeminy, because every second complex, it is an abnormal complex. So this is normal and this is a premature ventricular contracture. This is normal and this is a premature ventricular contracture. So every second complex is a premature ventricular contracture. That is the reason why we call it as ventricular bigeminy. Whereas here if you observe, first and second is normal, third is abnormal. So next, first and second is normal, third one is abnormal. So this we call it as the ventricular trigeminy. So ventricular trigeminy is that every third complex will be the abnormal complex, right? Then after having discussed about the rate and rhythm, you need to know how to make out the axis. First of all, what is the normal axis? Normal axis, it is minus 30 to plus 90, it is the normal axis, right? And plus 90 to plus 180, right? Plus 90 to plus 180, this is considered to be the right axis deviation, right? And minus 30 to minus 90, this is considered as the left axis deviation, right? Whereas minus 90 to minus 180, this is what is considered as the extreme axis deviation, right? Now how will you determine the same within the ECG given to you? So in the ECG given to you, lead 1 and lead 2, if both are positive, right, this is considered as the normal axis, right? Whereas in the given ECG, in the lead 1 and lead 2, if lead 1 is positive and lead 2 is negative, this is left axis deviation. And in the given ECG, if lead 1 is negative and lead 2 is positive, this is considered as the right axis deviation. Then followed by that, in the given ECG strip, if lead 1 is also negative and lead 2 is also negative, this we call it as the extreme axis deviation, right? So this is how you will determine the axis. So these are the three basic things what you need to check once you take the ECG: rate, rhythm and axis. Then you need to know the abnormalities of the first wave, that is the P wave. So if you take the normal P wave, normal P wave amplitude, it is less than 2.5 mm in the limb leads, right, less than 2.5 mm in the limb leads, or it will be less than 1.5 mm in the chest leads, that is V1, V2, V3, V4, V5, V6. So it will be less than 1.5 mm in the chest leads. Okay, that is about the normal P wave, right? And you take the abnormality of the P wave. In case of right atrial enlargement, we have what is called as the P pulmonale. So P pulmonale is that where the amplitude of the P wave, it is more than 2.5 mm. That is what is called as the P pulmonale. Then we have another important terminology called as the P mitral. Now what do you understand by this word, the P mitral? The P mitral is that the P wave, it is of M shape, and this particular P mitral, the duration of the P wave, right, the duration of the P wave, it should be more than 120 milliseconds. This we call it as the P mitral. So these are the two important abnormalities related to the P wave. Then followed by that, you need to be aware of what is called the PR interval. So after P wave, the PR interval. So PR interval, it is from the starting of the P wave to the starting of the QRS complex is what is called as the PR interval. And this particular PR interval, the normal is 120 to 200 milliseconds is the normal PR interval. Now, what are the conditions where the PR interval will be prolonged? That is in case of the AV block. So you take in case of the first degree AV block, where the pathology is in the internodal fibers, the PR interval will be more than, right, the PR interval will be more than 200 milliseconds, right? Then followed by that, you take the second degree AV block. So first degree AV block, the PR interval will be more than 200 milliseconds. And second degree AV block, you have Mobitz type 1 and as well as Mobitz type 2 AV block. So in case of Mobitz type 1, what is that you will notice is, you will notice that there is progressive prolongation of the PR interval. You have a P wave and then there is drop in the QRS complex. Okay, that is what is your the Mobitz type 1 AV block, where there is progressive prolongation of the PR interval and there is drop in the QRS complex. That means you have a P wave and you don't have the QRS complex. Whereas you take in case of Mobitz type 2 AV block. In case of Mobitz type 2 AV block, like what is that you will have is the PR interval will be constant, right? So you have a constant PR interval, right? But intermittently you have a drop in the QRS complex. You have a P wave but there is no QRS complex. So that is what is Mobitz type 2. So Mobitz type 1, progressive prolongation of the PR interval and drop in the QRS complex. Mobitz type 2, you have a constant PR interval and there is intermittent drop in the QRS complex, right? Then followed by that, you take third degree AV block. Third degree AV block, this is considered as complete heart block. In case of the complete heart block, there is complete AV dissociation. So there is no, right, there is no coordination between the P wave and as well as the QRS complex, right? So P wave and QRS complex, both of them are atrial and ventricular depolarizations, they are completely dissociated. That is what is called as the third degree AV block. So then followed by that, you need to be aware of the clinical conditions where the PR interval is being shortened. The PR interval is being shortened in patients with the WPW syndrome. In WPW syndrome, which is also called Wolff-Parkinson-White syndrome, the PR interval will be less than 120 milliseconds and you have the presence of the delta wave. So delta wave is nothing but the slurring of the QRS complex. That is nothing but your delta wave. Then followed by that, you will have a wide QRS complex. Right, then followed by that you have a wide QRS complex. So these are the features of WPW syndrome: short PR interval, the presence of delta wave, and then the wide QRS complex. So this is about the WPW syndrome, and which is nothing but the one with accessory pathway. And what is the name of the accessory pathway here? That is bundle of Kent. So that is about the abnormalities related to the PR interval. Then coming to the Q wave. So in a normal individual, the Q wave will be very small or it is completely absent. But what are the conditions where you will have the pathological Q wave? First of all, what do you understand by the word pathological Q wave? So pathological Q wave means it should be deep, right? Where the depth of the P wave, it should be more than 1 millimeter, right? Whereas the width of the Q wave, that is the wideness of the Q wave, it should be more than 40 milliseconds, right? And it should be 1/3 of the QRS complex. right? This is what is called pathological Q wave. Pathological Q wave, where is that you will have that in patients with the myocardial infarction. You will have that in patients with old MI. You will have that in patients with hypertrophic obstructive cardiomyopathy. You will have the presence of pathological Q wave. So these are the conditions where you have the presence of the pathological Q wave, right? Then followed by that, the QRS complex. So if you take the QRS complex, the normal QRS complex, it is around 70 to 100 milliseconds. 70 to 100 milliseconds is the normal QRS complex. And if the QRS complex is wide, right, that we call it as the broad QRS complex. And this is the ECG of monomorphic ventricular tachycardia. So in monomorphic ventricular tachycardia, what is that you will have is, you will have wide QRS complex and there is absence of the P wave. And how is that you will manage these patients is, if the individual is hemodynamically stable, we give amiodarone, and if the individual is hemodynamically unstable, we do DC cardioversion. Then the other scenarios where you can have the broad QRS complexes is in patients with right bundle branch block, and in patients with left bundle branch block, you will have the wide QRS complexes. So you can see that here in lead V1, what are the features of your RBBB? See, this is the ECG of the right bundle branch block. Now, what will be the ECG features of the right bundle branch block? That is, you should have M-shaped R wave in V1, right? M-shaped R wave in V1, right? Or you should have W-shaped S wave in V6. Right, W-shaped S wave in V6. So this will be the ECG changes in case of right bundle branch block, whereas you take in cases of the left bundle branch block. In cases of left bundle branch block, the ECG changes will be, you will have W-shaped S wave in V1, right, and M-shaped R wave in V6. Okay, so this will be the ECG changes in case of left bundle branch block. In both the bundle branch blocks, the QRS complexes will be more than 120 milliseconds, right? So that is about how the QRS complex abnormality will be. Next important is, you need to know the ECG changes in left ventricular hypertrophy and right ventricular hypertrophy. In left ventricular hypertrophy, right, you need to be aware of a criteria called the Sokolov-Lyon criteria. And according to this particular Sokolov-Lyon criteria, the depth of S wave in V1 and the amplitude of the R wave in V5 or V6, that should be more than 35 mm. Okay, this is suggestive of the left ventricular hypertrophy, and one of the most common cause for left ventricular hypertrophy is hypertension. Then you need to know the ECG changes that you will be having in right ventricular hypertrophy. In right ventricular hypertrophy, the amplitude of the R wave in V1, right, so this should be like more than 7 mm, right, or the depth of the S wave in V6, it should be more than 3 mm. So this is suggestive of the right ventricular hypertrophy, right? Then followed by that, you need to understand what is called as low voltage complexes. Low voltage complexes, you come across that in patients with pericardial effusion, you come across that in patients with the constrictive pericarditis. So what exactly you understand by these low voltage complexes is that where the amplitude of the QRS complexes in the limb leads, it should be less than 5 mm, and the amplitude of the QRS complexes in the chest leads, it should be less than 10 mm. That is when we use this word called low voltage complexes seen in pericardial effusion or the constrictive pericarditis. And we have another important form of the ECG called electrical alternance. So the electrical alternance is that where you will have a normal QRS complex and low voltage complex, normal QRS complex and then low voltage complexes. So you have alternating large and small complexes, alternating large and small complexes. This is what is called electrical alternance. You observe this in patients with massive pericardial effusion, and you also observe this in patients with the cardiac tamponade where you have the presence of the electrical alternance. Then you need to know the abnormalities related to the ST segment, right? So the ST segment elevation is what you need to know. If there is ST segment elevation from V1 to V4, that is suggestive of, right, V1 to V4, that is suggestive of the anterior wall MI. If there is the ST segment elevation in one AVL V5 V6, right, ST segment elevation in one AVL V5 and V6, that is suggestive of the lateral wall MI, So very important point you need to know here is, in case of anterior wall MI, it is the left anterior descending artery which is being blocked. In lateral wall MI, it is the left circumflex artery which is being blocked, right? Then followed by that, the inferior wall MI. In case of the inferior wall MI, in 2, 3 AVF, right? In 2, 3 and AVF, you have the ST segment elevation, and the vessel that will be blocked in this is the right coronary artery which is being blocked, right? And then followed by that, you need to know the abnormalities related to the T wave. See, the normal amplitude of the T wave is less than 5 to 10 mm is the normal amplitude. But where is that you will have tall T wave? Tall T wave, you have that in patients with the hyperkalemia, that to a tall tented T wave. Then where is that you will have the presence of broad tall T wave? You will have that in patients with the MI. In early stages of MI, you will have broad tall T wave. Then what are the conditions where you have the presence of the inverted T wave? You have that in patients with ischemia, and as well as in strain patterns like RVH and LVH. There also you will have the T wave being inverted. So this is a quick revision related to the ECG. Thank you very much.